So today is, as mentioned, myself, Dr. Pamo and Dr. John, we're gonna just give a brief overview of the COVID response in the Asia Pacific region. Um, I'm going to just start by talking about some of the generic tools that are available for COVID-19 surveillance and vaccination that we've developed as a core team. Pamela and John have had a lot of contributions here as well to this core development. And then we will discuss, Pamela will present a bit on what's being done in Sri Lanka. And John will talk a bit about what's being done in Laos. If there's a little bit of time, I might also mention what's happening in the Pacific Islands. And then we'll leave some time for Q&A as well. All right, so kind of the kind of main reason why we find the DHIS2 implementation has been scaling in many countries. So we have modules for surveillance and vaccination, and I'll talk about that in a moment. But really, what we've tried to do is build upon, during this pandemic period where there was a big rush, of course, to do things very quickly, because so many countries are kind of using DHIS2 routinely already, either for their national immunization programs or for their HMIS in some capacity. They kind of quickly made a decision to use DHIS2 for either COVID surveillance or vaccination. I'll go over those countries as well. We tried to leverage that capacity as much as possible, of course, because we can't really travel and things of that nature, and just being reliant on, I think, technical assistance to get these systems to scale. It's not really something that we would promote. So because we have built a lot of local capacity over the years, we tried to kind of leverage that as much as possible. And then, of course, with support from the HIS groups like John and Pamela's teams to kind of help this implementation further. And I see Tofik on the call as well. So Tofik is helping in Indonesia a lot as well with many, many things. Of course, we try to allow to make things customizable. So I'm going to talk about some of the tools available, but keep in mind that when I mention these, all of these can be modified to fit the needs of a specific implementation. So if in some cases it might work backward, like Sri Lanka started before we did, we looked at what they did and we took some of their guidance and made it kind of match some of the global guidance that we're sharing with others. So we reused some of what they're doing. In other cases, like in the Pacific Islands, they adopted the standards that I'm going to share with you and kind of modify it to their own settings. So, it can work both ways, either from community-driven efforts where we learn from them and vice versa, where implementations are kind of learning from some of the global tools that are available. We also work with a number of organizations, in particular WHO, CDC, on the surveillance and vaccination side, and Gavi as well, to develop or work from their global standards in terms of what type of variables need to be collected, what type of indicators need to be collected, what type of, especially in subject area approaches where in all cases, we might not necessarily be the subject matter expert, of course. We try to get as much information from them as possible to help both with developing the standards and tools that I'm going to share, as well as with capacity building, of course, when we're doing training and things of that nature. There might be certain areas that are not necessarily within our specific skill set, and we really work closely with other organizations to build that capacity further. Of course, then there's also the investment portion. There's been a lot of kind of concern about how we scale this up, training infrastructure, devices. There's been a lot of focus in particular on local costs, right? So there's been quite a significant windfall, I think, of funding for technical assistance, but getting organizations, capable and up to date, and ministries in terms of all the other infrastructure support, local costs, I think that has been, one challenge. But in terms of investment, because these systems are also used as their oftentimes main HMIS or just for immunization, for example, they've already made significant investments in ensuring that these systems are not going to fall over anytime soon, but there's kind of long-term funding for this. So, we tried to build upon this as well during the pandemic. And of course, as a digital public good, and Pamela will speak about this a little bit more, I believe, in his presentation. But DHIS2 is free and open source in terms of the software itself. As I just alluded to, there are many local costs associated with the implementation, and that is something important to consider, of course. But then we do make everything kind of available to the community. All of our applications, the DHIS2 application itself, the Android application, as well as all the development tools for the Android application, all of our training materials, and as well as any of the upgrades and other innovations that are shared by the community in the form of generic apps. These are all shared globally, and there's no licensing fees to use them. They can be downloaded and customized to anyone's liking based upon what's needed in their own setting. So I'm going to briefly talk about surveillance just as a bit of an update. And also, but mainly we're going to focus on vaccination today, but just so kind of people are aware of what's happening in both contexts. So back early last year, in response to what was happening with COVID, we quickly released several modules on COVID surveillance. And, as I mentioned, Pamela and John have had a lot of input into this. We learned a lot, for example, from Pamela's implementation in Sri Lanka for the port of entry screening. And in fact, we didn't have any global guidance at that time. We adopted a lot of what Sri Lanka did and shared this globally for people who were looking for something and didn't have anything at that point in time to screen people at their borders. There's also packages on surveillance itself, of course, recording the confirmation of the diagnosis, contact tracing, and then we have other packages that are meant for aggregate reports or just simple line listings, so that aren't as involved, that aren't necessarily case-based. Where we found the focuses on the implementation side is mostly on the surveillance, port of entry, contact tracing, kind of this case-based information, as well as the aggregate information. We don't have many cases where they're implementing just a kind of anonymous line list of some sort in the implementations that we've seen. So you can see on the map here, there's a number of countries where this is operational, still a number of countries that are developing this or considering this as a potential solution. And this is kind of spread out amongst various countries worldwide. Just in this corner here, during this kind of course of the implementation, there was an independent study released by Johns Hopkins University. I'll share this presentation with everyone here so they can get a look. But basically, they did an independent assessment of DHIS2 as well as many other platforms, ComCare included, and many other types of platforms. And just to kind of give an idea for people who are trying to adopt DHIS2 or anything else for COVID-19 surveillance at the time, it was focused on surveillance, but of course now we have vaccination as well. And we got a pretty good assessment from that as part of that independent evaluation. So that was very nice to see, and very good for the community to kind of understand that where we are in the maturity model in terms of our own individual processes. So the focus of this discussion today is mostly going to be on immunization, and here I have the different types of kind of guidance that we've been following from WHO. So this is kind of the scaling up of the WHO kind of vaccination planning guidance that is available. And what we've tried to do is respond to each of these items with the different kind of tools that we offer. Now, that doesn't necessarily mean a country is going to implement all of these tools at once or even over time. They can pick and choose what they want to use and modify those to their own setting. But from our own standpoint, we're trying to meet each of these kind of criteria within this WHO guidance that is available. So we have, well, I'll just go through each of these in more detail, just so we can kind of discuss them a little bit more. And we have a similar kind of operational standpoint for COVID vaccination where we are now. And this could be any of those items that I mentioned. So we could be looking at stock, we could be looking at individual immunization tracking. We could just be, entering the number of doses provided by day for different age groups, or, some other component of the package that I mentioned earlier. So in the Asia region, you'll see I've kind of highlighted some of the countries that are, operational or in development at this point in time. Bangladesh, Laos, Myanmar, Solomon Islands, and Sri Lanka, Vanuatu, and as well as Indonesia is working on various items. There's also some additional countries that India is supporting. They're not on this chart, unfortunately, not on this map, but there are some countries that India is supporting as well in the Eastern and Mediterranean region, as well as within the Southeast Asia region as well for COVID-19 vaccination. So I just want to talk about those 6 items that I introduced quickly, just so we can get a generic overview of things. And then John and Pamela are going to talk about specific country implementations in terms of what they've done and implemented in their context to either modify or customize things, or in some cases, just kind of create new tools that we have leveraged from the global side as well. All right, so I just wanted to start off with kind of the core immunization work. So what we've done, previously we had a previous kind of module on just routine immunization, right? So looking at BCG, OPV, et cetera, right? All those routine immunizations. And looking at that and the guidance that WHO had released, we kind of quickly modified this to meet the needs of COVID-19 vaccine delivery. What I'm showing here is based on kind of aggregated data, right? So this is not necessarily from individual data. That was kind of our first starting point. And, we saw several systems and countries kind of requesting this because it's just to scale up, given the resources they had and the familiarity with the system at the time. In some cases, it can be quite a bit easier if people really understand that aggregate workflow already. It's something you can deploy very, very quickly, right? So we made this as a first step, and this dashboard that you can see can be calculated from either individual or case-based data. If people want to take this and modify this to their own setting. This is entirely test data. We use the Lao system now for a lot of training and testing. Thank you to Lao for that. But we've kind of generated our own data for this purpose. So none of the data you see here is real in this case. We allow countries to kind of modify this to their own liking and needs depending on where they are. And we saw a lot of uptake of this initially when people were kind of scaling up and not really sure how to handle the vaccination when they just received a bunch of doses and were starting to vaccinate people. We also have some individual tools for stock, and we have both aggregate tools for stock as well as individual tools for stock, and I'll speak about that in a moment. But very much, DHIS2 is not really trying to position itself as an LMIS of some sort, but it's really meant to complement existing systems. So if you have data either coming in for a stock system, or you just want to know at your site, for example, how much doses you have access to, and how much you might need to request, or some basic planning around that. That's basically where we're trying to kind of help with. It's kind of at the end of the line, right? It's not really at the top where you're kind of managing all the orders and everything like that. It's just very simple information that can be used at a facility level to take stock of what you're doing. This stock module allows you to bring over previous values from the previous day. So, if I got a rundown of my stock on one day, the next day it'll bring over those values so I know what my starting stock is. And I can start with those values and kind of enter my stock the way I need to. So this is available and is being used in a couple places. And as I mentioned, it's not meant as a replacement for the LMIS. We also do have some prototypes for supply chain at the last mile. Once again, it's not meant to replace the LMIS, but this is kind of meant just at the kind of site level to really manage your day-to-day stock. This is still a prototype. It's not fully functional yet, to my knowledge, in any particular place. But what we're trying to do basically is use the barcodes that are available on various medications in order to register them in the system, so you can be able to track their stock within the facility itself. But compared to the other modules that I've spoken about, this is not as well implemented, and this is still very much in the testing phase. We also have kind of the core module for vaccination. This is case-based information that I'm showing you here. Once again, this is just from the testing system that I showed you. So a lot of countries in particular have implemented this solution or some variant of this solution, or made up something similar to this, basically following the WHO guidance that has been released in order to track every individual in terms of the vaccines they received and all the related dose information. We try to keep it quite simple. So in this case, you'll see some gray fields because they're automatically filled in. We try to keep this to around 3 to 5 fields in many cases, I would say, and in many implementations, because in a lot of cases, this has been the first time where we've seen a much larger uptake in real-time data entry, or very close to real-time data entry of individual case-based data. So either they fill in the paper form and then enter it on a computer pretty quickly, or they're kind of entering it just directly on the computer because they really want to have access to this information and this data as quickly as possible. And within this registry application, there's some functionality to schedule the second dose as well. And because of that, that functionality, a lot of people we see a lot more people kind of entering this data as quickly as possible. so they can also schedule the second dose and follow up on that in case there are missed appointments and things of that nature. And this is fully available on both web and Android for the case-based portion, as is the aggregate data as well. But what we've seen as kind of things have been ongoing, and there's been a bit more time to build capacity, a lot of people have been moving towards this kind of individual model for data collection if they started out for aggregate. So we have a particular use case, not from Asia, but from Africa, in fact, where they tried to do this at the beginning. It didn't really work very well. They switched back to aggregate data because they wanted to have something. And now they have a bit of a lull in their vaccine, the campaign. It's not as strict as required as before, not as intense. And then we see them kind of moving towards entering all their previous data as case-based and having some training, having some time to do training and everything on this as well. So we see a lot more countries now are kind of adopting this as things have gone on, whereas maybe they started with aggregate at the beginning just because of their familiarity and weren't as familiar with case-based. Of course, it's a lot more difficult to scale this up as Pamela and John will talk about. As part of our last kind of line on that WHO guidance was about vaccine safety monitoring, sorry. So we've also developed one module for adverse events following immunization, and this has been implemented in many settings as well. So on that map, I showed you 27 countries were using it for vaccination. They could be using a combination of different modules, including the vaccination registry and the adverse events following immunization as well, for example. So there have been a number of implementations of this. We really don't see that many implementations of an aggregate model for this. Of course, there aren't, in comparison to the amount of vaccinations and everything that you're providing, the amount of adverse events, the ratio is quite low in comparison. Of course, it still could add up, but being able to kind of link the adverse event to the case, that is obviously very, very beneficial. This module is not just meant for COVID-19, actually. We use a standard approach that has been defined by WHO for many different types of vaccinations. So it is also meant to integrate with routine electronic immunization registries as well. In many cases at the moment, the focus has been on COVID-19, but in terms of long-term support, we do see kind of how can this link up with a future electronic immunization record when that is available. All right, so that is just a quick kind of rundown of all the different kind of generic tools that are available from us at the moment. I also just wanted to quickly talk about vaccine and travel certificates. This was the kind of one other portion of that model. And this has been largely based on local innovations. This is actually not something that we have a generic solution for at this point in time that countries can kind of easily adapt. So certificates have been made both for based on surveillance as well as the vaccination modules that are available. I think Pamela and John will speak about the specifics that they've implemented as well. So we have these at the time when we were doing port of entry screening, for example, a lot of certificates were produced to allow travelers, essential workers, for example, to pass across borders and things of that nature. For vaccination, of course, we are having certificates produced to ensure that people, if they can verify that they received their first dose or they're fully vaccinated. So this is these are kind of apps that have been built on top of DHIS2. You can see this one here. It's built directly in the DHIS2 interface, but it's an additional functionality, and there's no generic solution because the certificates and the requirements for each country have been, very different, of course. We're trying to kind of just document these as best as possible and share these best practices with the community, but still this requires a bit of additional support locally. All right, so I wanted to hand over to my colleague Pamo here. I know he's here right now, and I'm actually going to allow him to share his screen. I have the presentation here, but he has some additional content there to share with you all. So I'm going to hand it over to Pamo and let him talk about the Sri Lanka implementation.
Thank you very much, Surajit. Good morning, good afternoon, good evening, everyone. First of all, a big thank you for all the questions. I tried to answer most of them that were there in the chat. Right. So in next 15 minutes or so, what I hope to discuss is the experience around implementing DHIS2 for COVID-19 in Sri Lanka. Uh, just to remind everyone, now we are kind of 18 months into the pandemic. And in Sri Lankan context, we received our first case of COVID-19 on 27th of January 2020. And there was this one very important event that took place on 20th January, where we had a discussion with the Ministry of Health to discuss how to collect information around COVID-19 in time to come, because we did not have a digital solution available to collect this surveillance data requirement. I mean, all the different types of data required to monitor the COVID-19. So these were a few of the concerns that were highlighted at that meeting. So in a nutshell, what ministry was more concerned about is to quickly develop an information system which can evolve. It's not just one-time development. It has to be able to evolve with changing requirements with minimal cost. And of course, you need to share data through this platform across multiple shareholders, stakeholders, beg your pardon. And then, of course, now it should not involve these lengthy government procurement procedures, which are already there in most of our developing countries. So to this discussion, we joined as HISP, as well as there were like a lot of stakeholders from the Ministry of Health, and we decided on an approach. So whatever approach was to, we opted for the platform DHIS2. Mind you, I mentioned DHIS2 as a platform, meaning like it can have its own customization within the DHIS2, and you can even go on building solutions on top of DHIS2. So what we were able to do in next couple of months was to customize DHIS2 and produce 9 different types of aggregate and case-based modules to collect COVID-19 related requirements and to collect data, right? And then the other component, like now, whenever we could not meet a functionality by customizing DHIS2, what we did was we developed components on top of DHIS2, because it's a platform rather than just a software. We could do that. And to do that, we did not have sufficient resources like the developers. And what we actually did was we organized a hackathon with, of course, participation of so many. It was not just his Sri Lanka or his effort. The ministry was involved, the government ICT agency, the volunteer developers, the University of Oslo, the DHIS2 community, everyone was involved to produce components on top of DHIS2 to meet requirements which are not doable within the standard DHIS2. So with that, we were able to produce this COVID-19 surveillance package, which after quick online training, we were able to deploy in Sri Lanka for local use. Now, DHIS2, as I mentioned in the chat, it has a very rich community. So what we did was we shared this information with the University of Oslo and DHIS2 community. And there were already few attempts and efforts on using DHIS2. So they kind of put everything together, formalized it, and produce a digital health data toolkit for COVID-19, which was then adopted by many countries. So this is just to show you the timeline. So in our first wave of COVID-19 early last year, we were able to produce all these components within a short span of 3 months period. So this was possible because of the existing capacity and the network that was around, which constantly helped the local people to develop these tools on top of platform. And then, of course, in the second wave, just to show that things are just ongoing, it doesn't stop. Like, for example, from May to October last year, we were kind of a bit complacent because cases were low and most of the things were like kind of static. But then again, our cases started rising. So we had to do some additional modifications and development for laboratory testing. And then at start of this year with the vaccination, we had to do some additional development and customizations to get the immunization data, as well as develop components to produce the vaccination certificates. So this is what we have overall, the large ecosystem of components for COVID-19 surveillance. What I want to highlight is initially, we just started off with this port of entry data collection, right? Because that was the initial requirement of the government last year, like around February, because like only the tourists we needed to track. But when the government policy as well as the epidemiology of the country changed, they decided to quarantine everyone who were incoming passengers. So that we needed to track data of people who are going into quarantine. And then the cases started rising. So we had to capture information from hospitalized patients as well as patients who were in the community, right? And when the critical ill patients were increasing towards April, they wanted to have track information about the ICU bed occupancy. So what I want to highlight is, like, with the evolving disease landscape and the epidemiology, the system was able to adapt and develop components on top of it. So this is what made us kind of resilient to change in requirements on COVID-19. And in fact, it was not just DHIS2, and we also used another digital public good called DWOC, which is widely used in India to produce certificates to generate the vaccination certificate, which I will explain towards later part. Right. So I mentioned the DHIS2 customization. Shurajit was mentioning, and he demonstrated what we can do within DHIS2 by existing tools. But what I want to highlight is, in case something is not available in DHIS2, you can always make web apps on top of DHIS2 platform. So the user stays in the platform, but he gets a totally different interface. So this is what we have done for contact mapping visualization. This is the initial application that we did in Sri Lanka last year. But then again, we realized that there were once we shared this information with the community, there were a lot of other countries who wanted same. So this is where the developers from Sri Lanka also communicated with and worked together with the other developers in the community and the University of Oslo and produced this generic app, which was then shared in the DHIS2 app hub, where anybody can download the package and install it in their DHIS2 instance and start using. So this is kind of a knowledge sharing that we do within the DHIS2 community. This is again another custom application we did to track locations, patients. And then another custom application to do ICU bed tracking. So here, what I want to highlight is even the simplest interfaces, as however customized it is for your requirement, you can produce on top of DHIS2. So this is kind of expanding the existing functionality of DHIS2. Right. So moving on to COVID-19 vaccination. Now, this work kind of started with the collaboration of the WHO Country Office in Sri Lanka towards latter part of last year. So what we did was we again designed a custom package or metadata package to incorporate all these requirements around COVID-19 vaccination. So the requirements what we tried to cater was to get set up an immunization tracker to get patient level data, and also to have a stock monitoring. This is not an exact stock management system, because DHIS2 has some limitations to do that. But we wanted to just monitor the stocks from receiving it at national level and the usage finally at the vaccination center level and the distribution. We want to keep some track, and we use this aggregated. Then they wanted to produce a digital vaccination certificate. So we had some tools for that. And also finally, a citizen portal where we link this government system, which is run by, which is on top of DHIS2, where the health ministry collect data, and how to make it available for the general public. That is basically vaccination appointment scheduling and also downloading the digital certificate. So now there were couple of aggregate customized module for this vaccination implementation in Sri Lanka. So what you are seeing here is just a sample vaccination aggregate data collection form. So we mainly use aggregate component for stock monitoring at national, regional, and vaccination center level, and also for aggregate vaccine data reporting at vaccination centers. But the major part of the implementation was on case-based data, that is about tracking of vaccinated people. So for this one, we used a DHIS2 tracker. So what you are seeing here is the tracker capture tool of DHIS to customize it the way we want. So in fact, this was developed before the University of Oslo released the standard metadata package. So this is somewhat different to what you see in the standard package. But the countries always have the freedom to customize it as per their requirements. And this is exactly what has happened here. So this tracker data we are collecting for vaccination information, then for AEFI, adverse events following immunization. And the latest tracker development is to track the cohort of vaccinated pregnant mothers across, this is in addition to the vaccination and AEFI information. We wanted to see how the prognosis of the pregnant mother as well as the baby once delivered if they are vaccinated during the pregnancy. So this is a new thing that country started, and we have customized DHIS2 to capture these requirements. And of course, there's a lot of analysis and visualization tools available for vaccination. So what you're seeing here is a dummy dashboard of national level data in a country. So for example, Sri Lanka. And what I want to highlight is there are a lot of analytic tools available, right, where you can analyze the aggregated as well as case-based data in DHIS2. And then, you can not only analyze them inside those tools, but you can put those analysis, save them and display in the dashboard. So, in couple of minutes, you can make a GIS visualization based on, different colored maps based on whatever data you collect per region that you can do in like no time when you are using DHIS2. And in addition to dashboard, you can also download data. A common requirement is whether we can download the data that we captured in DHIS2 for Excel, because so that they can do some other analysis or for record keeping purposes in vaccination and health centers. And there's always another tool available, like some advanced tool like SQL Views. But what I mean is, like, in case if you can't generate a particular dashboard or a table using existing DHIS2 tools, you can even have some advanced tools available to get that out. So the possibilities and applications are kind of unlimited in that sense. And then about vaccination certificate. So what we initially did, because we started this way back in latter part of 2020 with the vaccination, immunization registry, we designed, we did a custom development to produce a vaccination certificate. So if you're familiar with DHIS2, we have a tool called Tracker Capture where we are capturing all the vaccination information. So we modified it a bit to have this requirement. As Shurajit mentioned, this, of course, vaccination certificate is always going to be custom because it is not inherently supported by DHIS2. So we designed this sidecar service to generate a custom certificate which has a QR code, meaning like whoever who downloads this certificate and which has a QR code embedded, you can read it from a QR reader, and you can verify this certificate and download it because you are connecting to a government site. But then again, there was like some limitations, and there was this interim guidance on smart vaccination certificate, which was issued by WHO, which mandated to have, which recommended to have cryptographic verification of this digital certificate. So with this, of course, we had to change from this approach and to move to a different solution to produce this cryptographically verifiable solution. So what we did again was to have, because like we had this central backbone in DHIS2, where we had the normal data collection tool in DHIS2 Tracker Capture. We did this custom development. And we also use this other solution called DVOC, which is again a digital public good, which, as you are seeing here, it connects the DHIS2 and we makes enable to download the certificate. And also the government ICT agency, they designed this citizen portal. So there was good collaboration and which kind of had the vaccination scheduling information, as well as if the citizen wants to download the vaccination certificate, it was available. Right. There were a lot of challenges. In fact, like they wanted to pre-register the entire 16 million adult population of Sri Lanka. It was a major challenge, and this was a very large scale deployment of DHIS2. And then we were not sure about the platform performance. And then we also required to implement this cryptographically verifiable solution. So this is where multiple use of digital public goods. If you're not familiar with what digital public goods are, this is the definition. So basically, these are open solutions with standards, open source and open architecture. So we use two of them to have this solution, kind of like end-to-end solution to make available the digital certificate. So there were like a lot of success factors which were behind this implementation. So in general, like the multi-sector collaboration, like collaborating with the Ministry of Health and other government, the non-government, the development community, and also global collaboration with the HISP network and the University of Oslo was a major success factor. And we also had the capacity inbuilt in the country, which largely enabled all these things to take place in a very short span of time. And also use of multiple technologies, the digital public goods was also a contributing factor to achieve this success. So I will just stop here and hand it over to John and Surajit. Thank you.
About Lao, Lao DHIS2 is been adopted as their national system in 2015. We've been working on the aggregate system. Then they started with the tracker and the events. So the base was already there when COVID started. So we quickly needed to adopt on using of the DHIS2 for COVID surveillance. So when we tried to deal with the COVID, so it was not like creating a new system because people were already used to the system, what they've been collecting, and then we just wanted to enhance the system so that like we can capture the COVID information and produce the things what we really need to maintain. There were two aspects. One was on COVID surveillance. That started with like Sri Lanka, which was a very pioneer when they started in January on dealing with the COVID case surveillance and doing the registration follow-up, the port of entry, testing sites and all the things. And also a few other additional details which we added to our law. One was the hospital resource availability, because it was very hard to maintain like how many hospitals had actually the ICU, how many were having this things allocated for the COVID, how many were available, how many were filled. So it was essential to send the COVID patient to the particular hospital, not the hospital which is already filled. So those are the different things which we were trying to manage. The COVID surveillance and COVID case registration and contact registration was WHO package. Port of entry was also from WHO, but test instance and other things was slightly modified to meet the Lao case. Apart from that one, like we also have the COVID vaccination, which gets into the COVID case registration. But after that one, like it was the workload was too heavy because like Lao got 300,000 doses from China and from Russia to vaccinate, and then like there was more available resources, and it was too much for the health worker to get in all different details. So we tried to deal with this public self-registration in allocated hospitals where public can actually register for the COVID vaccination, where they give all the demographic details and also a few other things, and then they say approval and verification process, and then the vaccination date is serial down. So that's what we've been like trying to deal with. The next slide, just going to quickly talk about on what we have achieved. This is most about the COVID surveillance dashboard. We use both standard dashboard, which is what we get from DHIS2 when we customize all the things. And I know like one of the person in the chat, we asked about the target population and other things. So it's a very small things. One of this speedometer, it just says how many percentage of vaccination has been done. And this one is as a development instance, but that's please don't worry about the numbers. What it shows is how many percentage of the people have been vaccinated. In here, it is 11%, and in total, entire population, what was the things? The target population is decided by the Ministry of Health, and they say like what is the target population for the country and for different province. They decided based on their estimate, and based on that one, like we calculated like how much people have been like trying to get from the vaccine and all, and overall they also get how much was vaccinated, and also like how much people have been on the case surveillance issue. So every time there is a positive cases, you get like how many people have been positive, how many people have tested, how many people have been recovered, active, and died. And you can also get on the map. So those are the custom dashboard which has been built through. Next slide, please. This one is the pre-registration one. So the health department will allow for particular sites. Usually it's the central hospitals and the provincial hospital, and not every day, a few days, I just say 2 days in a month or or 2 days in a week, Wednesday or Friday. And then they also allocate particular timelines. Let's just say in 1 hour, you have 10 slot, and people can actually register it. And then people will, the health worker will call and verify, and then they say, okay, so you can come down for the vaccination. The first screen on the left-hand side is the public interface, where they can do all the registration, look for the appointment, the dates, and then they get a message saying that, okay, your appointment has been agreed. Please come to the hospital which they have selected. And then the second screen was the list of all the people who have been requested, and the health worker can actually screen through. They can call the people, or they can just SMS and just say, confirm all the different details, if they're genuine or not. And then they just allow the person to come for the vaccination. So that's some basic things to deal with the workload, and also allowing public to register, because not all the hospitals can do that one, but based on, according to law, use cases, we are allowing few hospitals who can do the self-registration. Next slide, please. So one of the key things about adaptation, because the COVID was like, DHIS2 was going on in Laos for quite some time, both tracker and other things. People were used to it. One of the things what we learned from the COVID is it's a strong collaboration between various health departments, the Minister of Health, WHO, HIS Vietnam, different partners coming together. They were already working together as a whole in making health system strengthening. But on the with the COVID, it actually strengthened and challenged more things for us to do. One of the things was like trying to use the existing resources and best way to analyze the data, having this innovation towards reduce the data entry burden, where we allow the public to enter the data for the vaccination. That was something quite new. The other one is on the COVID certification and report. The COVID certification, which Pramod presented, was to be certificate across all the things. And intermediate step is just like COVID report, that I have this report and you can come around on authorized by only Minister of Health, but not recognized by other departments. So that's something which is not technical, but it's more political things. But one major things what we learned is a agile implementation and acceptance from the different health department. It's more about linking up with your human resource, your supply chain, the hospital, which is basically under different, either in different ministry or different department, to collaborate together to deal with the COVID pandemic. So everyone, like the EPI, NCLE, the surveillance group, they all came together and they changed their work practices to manage and collaborate on this one. And DH has to help them. But one of the key things is how best the Ministry of Health, the health departments can work together to adopt this one. Not just saying, okay, we have a software, we have Excel sheet, we have this one, but more about work practices and routines and collaboration. And that's actually what is key in Lao, which move things together. That's all from me, Nick.
Great, thanks, John. So I know there's been some questions in the chat, but we'd like to open it up for questions for the last remaining time as well, if there are any remaining questions that people would like to ask us.
Thank you, Sir Nick, Sir John, and Dr. Pamad. So if there are other questions from our participants, we have also enabled the microphones if there are other questions or thoughts you would like to share. We will also be saving the chat history. Yes, I think someone turned on their mic.
Okay, if there is no question, I just want to answer one question about Danson, about like asking about the public self-registration. How do you quality control on the data? Because there is high risk of duplication on the self-registration. In respect of law, it's very less people are dealing with the registration online. And even if they do, there is a family folder and all things. If there is a duplicate, DHIS2 or us, we already, based on the 3 or 4 criteria, first name, last name, date of birth, age, and the family number, we just say it is duplicate. And we allow them to, we just say you're already registered. But we don't want to encourage. Maybe it was wrong, someone else has already put, like we also accept it, but it's also about the health worker and the health staff around to just verify it and reconfirm it. So that's also, but currently it's very less people are doing the self-registration. It's very low. If we did it in other country, it might be completely different, but Lao has very different workflow. So that was the things. But like it depends on the workflow and the requirement. We can do more strongest check, which we already have. But like just in for the case of Lao, we are trying to make it a bit easier for people to register.
Yes, thank you, Sir John. There's another message from Engineer Derek Fritz. So he says, I'm interested to know more about a paper-first workflow and how this can be implemented. My sense is that this will be important as vaccine administration ramps up. To limit to only digital-enabled sites may not support going abroad with a vaccination campaign.
Yeah, hi, Derek. The one of the things like there was a different challenges. Like for example, when we first started in Lao, the COVID case surveillance was very low. It was fine, but then it got like really, really high, and now even the vaccination is too high. So then the people could not really try to deal with the tracker or the case surveillance. So we also have aggregate case where they can just report how much they have entered, just as an aggregate, how many number positive, how many number negative, and all things tested. Because one of the most important thing is to just report it, but treat the patient. And then later they can work on the backlog on dealing with the case registration itself. So that's what we try to deal with it for two approach. We just say when the caseload is high, that's what also WHO packages. We also have aggregate package where they can just enter the number. And we also have the tracker thing where they can register it, but we have a denominator to compare. So you already just say we have 200 cases, but like you have only registered 100 case. That means there is some backlog on data entry. So that's what we have been trying to deal with in a few of the cases.
Thanks, John. Can I ask just a quick question on that point?
Yeah.
So that sort of assumes that there would have been some kind of paper-based card or record. I don't know if you might be using the yellow card. I know some countries are, but there must be some kind of card or record that the patient has, that the person who got the jab has. And is there anything that's on that card that will link back to the digital case record once that is back entered, as you say? And that was one of the things that in the WHO the first release candidate of the WHO guidance was this idea that there would be a way to link the paper card to its digital twin when the digital twin was eventually available. And actually, is there some kind of link there?
Actually, there is the paper is only with the health department or the health worker, not with the client. That's the sad part. If it was with the client, it would have been understand. Right now in Lao, we don't have that one. Okay. Like I understand, like what are you saying? Like you get the card for the client, but that's not really the case.
Okay. I thought
Yeah.
we would have reused a pattern of like we do with the babies, where the babies got their vaccination card. We're not doing that kind of thing.
No, we just like a simple things which has no cases found. So they've been like trying to deal with, and especially for the vaccination, it's not so much. It's very less right now. Only
Okay.
now it is getting up.
Yeah.
Yeah.
They're still waiting on the COVAX shipments.
Yes, exactly.
Thank you very much.
Maybe Pamo, do you want to add quickly about the certificate? What's going on in Sri Lanka?
Yeah, I will quickly clarify how we are using the paper twin or paper records. So what happens is, like in Sri Lanka, we are issuing a vaccination card, like just like any other vaccination we issue to the client. So that is a client copy. We also collect some paper. So what the most important thing is like how you plan your vaccination campaign. So you have to be prepared, like in case, even if you try to go full digital, it doesn't work out. You need to have paper plus some other offline digital collection. So what we do is, like for all the vaccination centers, we have shared with them the paper forms, which kind of like the paper registry, and then also a Excel template so that we can later on import data into DHIS2. So both these are there in the centers, and there have been multiple scenarios where like they have encountered some issues in real-time data entry, infrastructure, can't access server, and so many things. So when that happens, they collect that data into in whatever these offline formats. And also about how to link it, we are using the national identity card number. So all the citizens have it. And as I mentioned, we have pre-registered all entire population. So what happens is like, because the population data, the name, address, and few other information is already there. You just search the person when he comes to the vaccination center with that number. And then you just pull up that record and just mark the date and the product. And so very few data elements they have to capture that way. But of course, exceptions are there. And we, in the training, the training we provide to the vaccination centers before implementing, that's where we try to highlight all these difficult scenarios that you might encounter.
Thank you.
And there was also a question about how it support the digital, the general routine systems. So like there are multiple instances. In fact, like this is, about COVID-19, what happened was it was not just using technology for COVID-19. It kind of create a culture of using digital technologies. So what we have seen, like, for example, I can highlight one scenario in our nutrition system in one post-conflict district in Sri Lanka. So they have been using these technologies like mobile data collection. So the COVID-19 pandemic kind of, gave them a competitive advantage over other healthcare workers in other districts because they were already using technology. So with that, they were technology enabled. They were more, they had more capacity to join Zoom calls for other routine, like review meetings and all. And they all, but we have also seen, like I have not included in the slides, some reporting rates of routine systems. They're like in the times of lockdown where you have disruption to service delivery, the rates go down. But as soon as you open the particular area for routine services, then it comes back to normal. So we have seen it with a couple of systems that were previously there, the routine systems. So that just try to highlight like how this digitally enabling helps the routine systems as well. Over.
Yeah. There is also one question on Nirmala on like, could you please clarify on reporting status from status on Sri Lanka and Laos? How happy you are with your data quality and HR challenges? Just to give a big things like, in Laos, only 30% of the people have 30% of the places have internet accessibility. It's not all the health centers, very few places. All the district hospital, provincial hospital has the internet. That's what we are hoping for. And again, data quality is something which is nothing to do with technology or anything. It has a collaborative effort. So that's why like we have both aggregate and case-based surveillance where we can try to compare across how things are. And it's nothing that a health system technology can solve, but together in collaboration with Minister of Health and the local partners, we can try to clarify and work through HR challenges is always there. But I guess like especially in a limited resource country like Laos, there are so much people, very nice people working in different departments, which we can collaborate and use during a pandemic situation, and they are all helpful. It's just only thing is to integrate and work with them, because through that one we can try to really improve the challenges what we face. Pramod, if you want to give a clarification on that one, or if you want to add anything.
No, I perfectly agree with you about data quality and human resources infrastructure, John. Just about how much of data we capture, I replied in the chat. So right now what we have seen is the real time, it ranges somewhere between like 30% up to 50% in centers. So, but we have seen like most of these centers, they have some offline data that they have captured in Excel and the paper forms that they try to enter. But as John suggested, like you always need to have this balance between, so you need to have the aggregate figures. You always try to compare the case-based data with that. The value is like, in case if you're going to generate a vaccination certificate, it doesn't really matter whether it has to come real time or not. Like if it is for traveling purposes, people who need, if the data is there, they can get the certificate. So that's what we try to kind of establish as of now.
All right. Thank you to our speakers. I think we've reached the top of the hour. If there are other questions from our participants, please feel free to contact us so we can connect you with our speakers. And once again, we would like to thank Sir John, Sir Nick, and Dr. Pamod for sharing their work with the AeHIN community. So to officially close the session, I would like to call on AeHIN Chair Dr. Bunchai for the final words.
Okay. It's very enlightening, and thank you very much for everyone to join the AeHIN webinar. We are grateful that we have learned and what you have shared, and then working in this Asia Pacific in Asia. So thank you very much. I officially close the webinar. Thank you. Bye.